Good morning, everyone, and thank you for being here. My name is Andrea Rasser, and today we are going to talk about something that is really changing life insurance underwriting today, and that is going to be weight loss. Specifically, we're going to dive into things such as bariatric surgeries, the latest and greatest in GLP-1 medications. That is going to be a hot topic. Comorbidities that come into play when we're looking at build and weight loss, and how all of this impacts your clients' ratings and therefore your placement ratios. So here's the bottom line. Weight loss, it's no longer just a build chart issue. You know, we spent years just looking at build charts, how it's your client's height and weight. But this is no longer the case. This is now a mortality modeling issue. It's a disclosure issue. There's a lot of things that are not disclosed, is what we're finding when it comes to recent weight loss. And it's a case strategy issue. We need to make sure that we are setting these clients up for success, setting you up for success, and presenting these cases in a way that we can win. So what we're finding right now is that reinsurers like Swiss Re, Hanover Re, Gen Re, they're some of the more common ones. They are actively publishing research right now on how these GLP-1 drugs and surgical weight loss may actually reduce mortality long term. But more underwriting, it's still going to be cautious in the short term is the thing. So what we're going to go over today is what the carriers are looking for, where agents tend to get tripped up, and how we can position these cases to win. All right, so why does all of this matter? Let's start with the big picture. Obesity, it is one of the most powerful mortality predictors in life insurance. Reason being is that when it comes to comorbidities, a person's weight is the biggest indicator of their long-term health. Weight comes with the most amount of comorbidities of all of the things that we underwrite for. Obesity is strongly associated with an increased risk of cardiovascular disease, type 2 diabetes, stroke risk, certain cancers, chronic kidney disease, sleep apnea. There's lots of things that come into play with build. Typically, if somebody is severely overweight, they're going to have another health history kind of combined with that. It's not typically just build that we see when we start getting into those higher levels of obesity. So when carriers are pricing obesity, they're not just pricing based on your weight. They're pricing downstream for extra disease risk. They know that obesity is going to likely come with other comorbidities, and they take that into consideration when they're pricing for build. So what we've seen, some of the trends in the US are that over 42% of US adults are obese. These are obviously higher than they've ever been in history. Nearly 1 in 5 children and adolescents have obesity. That is becoming far more common, and severe obesity, or a BMI of over 40, is affecting roughly 9 to 10% of all US adults. So it is incredibly common. It is an issue, and again, it does come with other comorbidities. But health aside, there's an economic impact as well. Obesity-related medical costs in the US alone exceed $170 billion annually. And then we found that individuals fighting obesity also have higher medical costs every year, anywhere from $1,800 to $2,500 per year than those at a normal weight. But with all of that being said, and this is important, this is what's changing in underwriting, is that not all obesity is equal. BMI alone does not tell the full story ever. Two clients can have the same BMI and one be completely metabolically healthy and another one, same build, be insulin resistant, hypertensive, pre-diabetic, maybe they have sleep apnea, maybe they don't. Um, Something that I see at least once every couple months, and I wouldn't be surprised if you hadn't run into this as well. I'll get that phone call from that agent. The guy was rated table 2 or 3 or 4 because of his build. And the agent says, Well, I know what his BMI is, but he's a weightlifter. He's a bodybuilder. He works out every day. Um, it there was a time it really didn't matter if he was a bodybuilder and worked out every day and it was all muscle mass and there was no body fat. The build chart was the build chart was the build chart. You were going to get what you were going to get based on your height and weight. That is not necessarily the case anymore. Underwriting is increasingly looking at overall metabolic health and not just the weight. We can now tell the story and explain, that this person's a bodybuilder or whatever the case may be. Those things are taken into consideration more now than ever, and especially now that things like these GLP-1s and bariatric surgeries are in play. We're just seeing underwriting look at this in a much different light. So first, we're going to briefly look at our bariatric surgeries. These have been around for years, so we're not going to spend a whole lot of time on this, but it includes things like gastric bypass or the adjustable gastric banding. We've seen those for a long time. They're not new. From an underwriting standpoint, they are not automatically bad. I know some people think if you've had weight loss surgery, there's this stigma and it could be rated and so on and so forth. But in fact, long-term data shows that sustained weight loss after these surgeries does improve mortality risk significantly. So surgery is not a bad thing. If somebody has had surgery, we just need to make sure that we present the things that the carriers want to see. They're going to want to see 18 to 24 months post-surgery. They want to see that that weight has remained stable. The client's not putting that weight back on. They want to know there were no major complications. There can be complications with any kind of surgery, so they want to rule those out. They also, especially with the gastric banding and such, they want to watch for nutritional deficiencies because that can also come into play. And then controlled comorbidities. So if you have somebody who has lost a lot of weight and their diabetes has improved, these are the kind of things we want to show. All that weight loss and all those improvements are great, but they're not going to count as much if the other comorbidities haven't been affected as well. So if we find all the weight has been lost and the sleep apnea went away, that's great. If we find out all the weight's been lost, but the sleep apnea is worsened and diabetes has worsened and the labs are bad, then that changes the whole story. So they're always going to look at the control of the comorbidities as well, not just the weight loss that has occurred. So here, as I just stated, they're going to look to see if the weight's stable. Obviously, they're going to be a little worried about regain. People are likely to regain after these surgeries. And so that's something they watch very close. And again, lab stabilized and such. Some of the best things that agents can do is kind of wait until the weight plateaus. We don't want to send in a case 6 months after surgery when they're in the midst of losing all this weight very rapidly. Obviously, if the client needs coverage now, we're going to write it now. We don't have to wait, but we're going to get a better rate class if we wait until that weight has plateaued and it has remained stable and we show that they are not instantly regaining that back and so on and so forth. Obviously, we're going to want updated labs and physicals. That's something the underwriters are going to insist on seeing. And anytime we can document the stability, write a cover letter. Those cover letters go a wrong way. Don't ever underestimate the power of a cover letter. Any part of the story that we can tell the underwriter that helps their cause and helps us in not having to order extra things. Like APSs or such. I mean, anything we can answer ourselves is going to be good. All right. Now, the big one, GLP-1 drugs. These have been our big game changer. Kind of the elephant in the room, if you will. But I think we've all heard of them now. We see them on the news all the time or in the ads. Semaglutide, tirzepatide, some known as Ozempic, Wegovy, Mounjaro. These drugs, these were originally designed for diabetes. They're now being widely used for weight loss. And the reinsurers have published modeling suggesting that widespread GLP-1 use could actually reduce all-cause mortality by over 5 to 6% long-term in developed markets. And that is huge, absolutely huge. Here's the catch. The underwriters are not pricing for long-term population modeling. The underwriters are pricing individual risk based on what's happening today. So it is important to note this long-term mortality change. But some of the big issues that the carriers are really kind of grappling with are, again, going to be durability. We don't know what's going to happen with these clients once they stop the medication. Weight gain is obviously very, very common after somebody loses an excessive amount of weight. But we don't know what that looks like long term with these GLP-1 meds. They're just too new. We know weight gain is common, but we don't know how much so. There's just not enough information out there. And then disclosure. This has been a big one with these medications. Carriers are noting that there's a huge disclosure gap. Many applicants do not think that they need to disclose their weight loss medication journey. I don't want to say by any means that clients are out there lying, because I don't think they mean to lie about it. I think they really don't understand that it matters. I think that since it doesn't always require a prescription from their primary care physician, they almost see this as an over-the-counter thing. They are not over-the-counter. You do still have to work with a physician. It just so turns out that a lot of these physicians are online, web-based. They're not having to go in and see their primary care guy. And so they don't see it as the same as like maybe a cholesterol med. And so when they're sitting there with the paramed examiner, they don't talk about it. They don't think about it. It's just something they're doing on their own. It's not really regulated by their physician. So it's just not being brought up. And then there's also some underlying risk there. Is the medication actually being used for diabetes, for weight loss, severe obesity weight loss, or is this just cosmetic weight loss? That's something they are going to look at too, because there are side effects that come along with these drugs. And while the benefits do seem to outweigh the side effects, if somebody is truly at a healthy BMI and doing this for cosmetic purposes, that is going to be viewed differently than somebody who is severely obese, and this is actually helping their morbidity and mortality. So what we're going to kind of look at is how it's being underwritten today. If a client is actively on a GLP-1 and they're losing weight rapidly, most of the carriers, they're going to average that weight loss over 12 months. So if they've lost 80 pounds in the last 12 months, they're going to add 40 of that back when they do their build. If the client is stable, has been on the medication long term, we're talking that 12 to 18 month range, then the carriers are more than likely going to look at the last 12 months where it's been stable and not add anything back. And if the medication was recently stopped, underwriters might add a little bit back. They may be a little concerned about that potential gain, but if it's been stable for over a year, then that is going to be a moot point. So what the agents really need to make sure they're asking when they're talking with their clients is, how long have you been on this medication? What was your starting weight? They always want to know what that peak weight was. And then, are you planning on staying on it long term? Is this the kind of thing that they're just taking for 6 months and then they're stopping? Is it something where they're going to be on maintenance for the rest of their lives? Like, these are stories we want to tell the underwriter so they kind of know how to look at the whole picture. All right, and then where this really becomes interesting is with the reinsurance data. We're finding that if these GLP-1s are adopted widely and they're sustained, population mortality could decrease meaningfully over the next 20 years, other than that 5 to 6% we talked about a couple slides ago. Obesity has been one of the very few, maybe only, but very few forces that has actually been pulling US life expectancy backwards. With all of the advancements we have in medicine, mortality has obviously gotten better over the years, but obesity is one of the forces that pulls it backwards. And these GLP-1 drugs are quite possibly the very first scalable intervention that could bend that curve. We know that this could have major changes over the next 20 years, but we're still very cautious. And we're cautious because the long-term data is still developing. There has not been enough time in research for us to know what long-term complications may come with these drugs. And one of the other things that leave us very cautious are the cost and the insurance coverage and the variations there. The cost can be prohibitive to those who need it. It can definitely limit availability. And then on the flip side of that, we're seeing a huge increase in unregulated use. We've got people, like I said before, going online and just ordering them online. You have to answer a couple medical questions and you maybe have to prove your identity, but that's it. There's no doctor checking on you to make sure that you're not overusing, underusing, that your labs are in good order, and then you're not becoming malnourished. Malnourishment tends to be a pretty consistent complication, I guess you could call it, because you're not getting the nutrients that your body needs. And so we see a loss in muscle mass, and the labs can really get kind of wacky. So long term, we just don't know what the issues are going to be. And then, again, what happens when this client discontinues therapy? Are they going to just gain 100 pounds back within the next year? Is it something where they're going to have to be on a maintenance pill or drug or injection for the rest of their lives in order to keep that weight off? There's still just a lot of unknowns there. And so the carriers, they're balancing optimism with prudence. I mean, we know that long term this could be amazing. We know that long term it's helping with comorbidities. It's definitely going to improve on people's health. But the bottom line is, while it is improving overall mortalities in more ways than one, there's still just a lot to be learned as this research continues. So how do we present these cases? Well, one example we have is this gentleman here. He's 45 years old. His peak weight was 320 pounds. He was definitely going to be a rated case. However, he was on GLP-1s for 14 months. His current weight is down to 250. Now he's in that preferred to standard rate class just based on build alone. His labs have improved. His cholesterol looks good. His blood pressure has been great. His A1C was previously elevated. He was in a pre-diabetic range, and now his A1C is normal. So being able to show those labs, show those improvements, emphasize how long this has been going on, that this is not just, in the last 6 months, show that stability, and then also be able to show that he was seeing a physician, that this was monitored by a professional. He did not just rapidly lose a whole lot of weight without any kind of assistance, with a physician monitoring the progress. This is going to be our best case scenario. This is a situation where, we put together the right cover letter, we told the whole story. We can actually get this gentleman approved based on his current build and not his peak weight or even an averaged weight. All right, then we have this 52-year-old female. She actually opted for surgery 18 months ago rather than taking the pills. She has lost 90 pounds. It has been stable for 10 months, so she's maintained that weight loss. She's not regaining. There have been no complications pre-surgically. There were no complications. Everything went really well. Malnourishment has not been an issue. She's processing everything the way her body should. Of course, we're going to want to provide the surgical report. I mean, the underwriters are going to order an APS no matter what. That's just automatically going to happen. They will definitely want to see recent labs, and we're going to want to emphasize maintenance, like how she plans on maintaining this. Obviously, with surgery, that's going to be different than the GLP-1s because it's not like there's a maintenance drug for this, but we just want to emphasize at least that stability, the maintenance, the changes in her comorbidities, and with the proper cover letter and medical records, this one also should have no problem getting a favorable approval through underwriting. And lastly, we have a 38-year-old female. She has lost 40 pounds in the last 4 months using a GLP-1 injection. She is still losing weight very rapidly, so there is no stability to show there. Her build was not highly rated to begin with. This was more of a cosmetic situation. In these situations with this rapid weight loss, this is where we start to see issues with labs, where we start to see that their body is a little bit malnourished, they're not getting the nutrients they need. In a situation like this, it's probably best to delay until there has been a plateau in the weight loss and the labs are back to normal. Now, obviously, if somebody needs coverage now, we're not going to tell them, no, you can't get coverage because you're currently losing weight. Yes, you can get coverage. However, they are going to add back in at least half of that weight loss. They're going to average that out with the peak. And so this is a case that's going to be a little bit harder to place potentially and probably going to have a table or two on there to just kind of the difference in the things that we see when dealing with these medications. All right, so just some of the key takeaways there. Always ask about the weight loss medications. If they tell you they're on weight loss medications, definitely find out which ones, find out the dosage, find out how long they've been on it. Make sure they know to tell the paramed company. Again, they don't think it's a big deal. They might not mention it. The paramed examiner is not going to come right out and ask. So make sure you tell them to tell the paramed company. And then at the end of the day, when you're not sure, give us a call. We're obviously in the middle of a shift in the underwriting philosophy when it comes to weight loss. So if you are unclear, just give us a call. Weight loss is no longer about build charts anymore. It's about metabolic health. It's about the treatment options that are out there. It's about full disclosure. It's about the long-term mortality improvement, not just the weight loss improvement, but actual mortality improvement. So while the reinsurers are signaling that mortality trends may improve, remember the current day underwriters are still being cautious. Give us a call. We can talk about what that means for you and your clients. We have fact finders on our website. Some of these, we have some that are just very generic. They cover a little bit of everything. And then if you have something more specific, we have our NAILBA guide out there where you can find more ailment specific questionnaires, whether it be CAD, diabetes, or weight loss. And you can also pre-screen with me. You can email me at andrea@iamsinc.com and we can talk about that history. You can give me a call. You can send me a courier pigeon. That's fine. Call your marketer if you'd rather talk with your sales director and they can work with me one-on-one. We will figure out the best carrier for your client. And with that, don't forget to follow and like us on Facebook and LinkedIn. And I sure hope everybody has a wonderful Monday and stays warm. Seems like there's a lot of weather out there across the country today, so be safe. Thanks so much.